Welcome to our webcast on pioneering physician peer support programs. I'm Dr. Dana Welle, Chief Medical Officer for the Risk Authority Stanford. We are bringing you today's webcast in partnership with Aon, Lockton UK, and MedPro Group. Support for physician is gaining national attention. Recently, a photo of an emergency room physician, visibly upset and crouched outside the emergency department, went viral. The physician was grieving the loss of a 19-year-old trauma patient. Many social media sites opined on this tragic vision, but one theme stood out. Doctors are affected by tragic events and are often not given the tools and support they need in difficult situations. In fact, in the instance of this emergency room physician, as is often the case, he returns to work to finish his shift with a stoic face to treat his next patient as if nothing happened. Numerous studies document doctors experience high levels of stress, leading to physical, psychological, and emotional harm, and eventually burnout. It is well known that a physician experiences burnouts at a higher rate than most providers, with some studies quoting rates as high as 40 to 50%. Today we are fortunate to have two thought leaders with us who are working diligently to change this. Dr. Joe Shapiro, Chief of Otolaryngology and Director of the Center for Professionalism and Peer Support at Brigham and Women's, is a national expert and one of the pioneers in the field of physician peer support. Joe, it's a privilege to have you joining us today all the way from Boston.
Thank you, Dana. It's really a pleasure to be here.
Thank you. Dr. Bryan Bohman, an anesthesiologist and currently the CMO for University Healthcare Alliance, was the Chief of Staff of Stanford Hospital when he implemented a cultural shift and started the Stanford Physician Wellness Committee and led the effort to bring peer support to Stanford Hospital and Stanford Children's Hospital. Thank you for joining us today, Bryan.
Thanks, my pleasure.
During our hour together, Drs. Shapiro and Bohman will be discussing their journey into peer support programs, what they are, how they work, challenges and lessons learned, and finally, best practices and future directions. As I mentioned, Dr. Bryan Bohman began the journey in Stanford to physician wellness and peer support programs several years ago. Bryan, what prompted you to recognize the need for a peer support program?
Well, as you mentioned, I was Chief of Staff at Stanford when we started the Wellness Committee at Stanford. And I think that my mindset was probably affected by an incident that had happened just a few years previously to me, which I thought I would relate to the viewers because I think that it illustrates sort of what we're talking about when we talk about these sorts of critical incidents that are helped by peer support. I was mid-career in my anesthesia career and probably 15 years of doing anesthesia and was doing a routine orthopedic case one day. And suddenly, my patient was dead in the operating room. Pulseless, no EKG tracing, huge resuscitation effort, no success. And the aftermath of that experience for me, even a pretty confident, experienced clinician with a lot of support in general in my life, was really difficult. When the patient left the operating room was taped off with yellow tape so that the investigators could come later. I'm racking my mind, what went wrong? What did I do? Did this patient have hypotension that I didn't notice? Did I miss an arrhythmia? I didn't know the answers to any of those questions, and they were downloading the data from the monitors. It felt like I'd committed a crime. And the risk management people, because they're right about this at that time, said, you can't talk to anybody about this, it's discoverable. So I felt very isolated. I didn't feel a lot of support, even though people were nice to me, it didn't feel that way. And I didn't know that what was missing. I didn't know about peer support programs at the time, but that was a very powerful experience for me. And so later, when I was Chief of Staff, the whole idea of wellness for the medical staff was something that hadn't really been high on people's minds at Stanford. We didn't have a wellness committee. But as Chief of Staff, I saw a lot of results of the pressures that are more and more on physicians in practice in all of our organizations, I think. Just increasing emphasis on productivity, on How are you doing on your quality metrics? How are you doing on your patient satisfaction? How are you doing on your professionalism? All of which is really important and very valid, but what I was seeing is people coming into my office who were sort of being pushed off the edge of a cliff occasionally. And we had at our institution a pretty good program for helping physicians who were in really severe distress. But what we didn't have is anything that would sort of address folks before they got to that point and would help them to cope with sort of the everyday increasing pressures that I think that clinicians are experiencing across the country. And so we started the Wellness Committee. And we started thinking about how do we address the issues that we formed to address. And one of the things we decided is that we really needed to do a survey because being in an academic institution, data speaks. Opinions, anecdotal evidence isn't so compelling. And so we decided to do a survey of our medical staff to see what was going on. These data are not from our medical staff. They just show the prevalence of burnout among physicians nationwide. And you can see there's some variability between specialties, but really the burnout rates between above 30% to above 50% have to be considered unacceptable by any reasonable person in a profession like medicine where folks are selected for being fairly resilient, capable of a lot of hard work. And so we thought we would see how we were doing at Stanford. But what we wanted to do is not focus just on burnout. We wanted to think about professional fulfillment, sort of the flip side of burnout. We want to know how people were doing in their careers in general, look at the positive as well as the negative. We define fulfillment as satisfaction or happiness as a result of fully developing one's abilities or character. And our hypothesis as a committee and the way that we present ourselves to the organization is we believe that physicians who have high professional fulfillment will give better care, will have better quality outcomes, will produce better results for the patients and for the organization. Our results were 25% of our physicians were burned out. That's lower than national averages, but luckily nobody in our institution said, oh, well, that's okay. 25% is not bad. 23% had high professional fulfillment, and we'd like to see that number very, very much higher as well. And then what we found in our survey was what was it that determined this high level of professional fulfillment? And what it was perceived appreciation and peer support. And those are the numbers that on this slide that show the amount of the effect. You can see that appreciation was a little bit larger than peer support. But what our committee thought is that you really can't show appreciation if you aren't supporting people, and especially in these incidents such as the one I described where we're sort of leaving our wounded on the field without support. And in order to develop a culture of support in our organization, we felt we needed to do something about that. Why do you do peer support after clinical events? As I've just related and as studies have shown, there's a lot of distress after these events. It affects folks emotionally, it affects them in their personal lives, it affects them professionally, and people do not currently feel supported. And I think that there's a lot of evidence also that it puts their subsequent patients at risk, and it puts the physician at risk for burnout at a higher rate than even the high rates that we already have. So we decided in our wellness committee that this was the first intervention that we should do in our organization. I think Joe's going to get into this a little more later, but one of the things that we thought is that we really need as an organization to address the historical medical culture of the physician as some sort of superhuman who is personally responsible for everything about patient outcomes, that, you know, if only the physician is perfect, the outcome will be good. It may have been true in some sense 75 years ago. In today's team-based, really hyper-complex care, this is just an outmoded attitude, and we need to get over it as a profession. The idea of physician heal thyself. Culturally, we are taught that we shouldn't take time to take care of ourselves. And most of us have ingrained that in our own personalities, and we really don't have the inclination to do that. We feel that it's a sign of weakness. So in 2013, with this sort of thinking behind us, we decided on our committee to look at peer support. We looked nationally to find out who's doing this. How do we do this? What would we do if we were going to have a peer support program? And we didn't find much until we stumbled onto Joe's program at Brigham and Women's Hospital. And it was clear that Joe had a program that was working, that had been well thought out, that had there was something that really we could relate to as an organization. It was at a peer academic institution, and we decided that that was what we would like to model ourselves after.
Great. Thank you, Bryan. You highlighted the scarcity of peer support programs when we were looking in 2013 when we found Joe. Joe, your program's been around since 2006. The same question to you. What prompted you to start a peer support program at the Brigham?
Well, very similar to what Bryan was discussing. It was really clear to us that we had moments in our careers and our lives as physicians and also other clinicians that were where we were extremely vulnerable to feeling awful. And we also noticed that it was a time when we tended to leave each other alone for lots of good reasons, but reasons that we now understand are not justifiable. So our institution had recognized this, and we looked to start a peer support program modeled originally after the first responders, who have a very, very long tradition of being there for each other very explicitly and assertively after any of their members experiences anything potentially stressful, emotionally stressful. So these are the firefighters and the EMTs and the police officers. And we actually had them come and train the first cohort of peer supporters to be able to reach out to each other after something had gone wrong. Again, it was in the context of what Bryan said was we were noticing there was so much stress, especially after adverse events. The other thing that we started to look at very carefully was, in trying to design a peer support program, was, well, what are the emotional impacts after adverse events? And what we discovered, and I think this has been well borne out in the literature, is that, first of all, it's very individual what somebody feels, but it's quite common that we have some emotions that we all share as clinicians. And just going over them in general, one is, of course, we're sad. I mean, we're sad to see another person suffering. Followed by that is a real deep sense of shame. And I think the shame has really gotten in the way of people, of our recovering after adverse events. And so you have to look at, well, why would we feel ashamed after an error? And there was a researcher named Helmreich who actually looked at the similarity between the enculturation in aviation and that in medicine. And he found that both stress a need for perfection and a deep sense of personal invulnerability. So if we are trained to be perfect, that is, we have expectations of perfection, which is completely unrealistic. Humans make errors at actually quite predictable rates, but if we're trained to believe that we really should be perfect, then when we're not, it's really hard to reconcile. And that feeling is often turned inward and to ourselves as, I am deficient, I'm bad, I'm not qualified, I'm incompetent, I shouldn't be doing this work. And then as a profession, we've been trained to look at each other that way after adverse events. We just can't see that in our colleagues. So the other very important factor is that medicine actually selects for perfectionism and grooms us to be perfectionistic. And perfectionism itself is a risk for a lot of bad things like depression, anxiety, burnout, and even suicide. And the suicide rate in both men and women physicians compared to the normal U.S. population is absolutely astronomically higher. And again, we all feel like we have to start doing something to prevent that. And this is a form of prevention. So the other emotions I think that a lot of physicians and other clinicians feel, one is fear. And the fear, there's a lot of reasons to be afraid after something goes wrong. One is that we have a really long-standing devotion to our patients and hope that they trust us, and usually they do. But when something goes wrong, especially if we've made an error, there can often be a sense of mistrust by the patient or even the patient's family, which again is that's up to them. They are entitled to feel whatever they feel. But for us to have that breach of trust and to have a patient or family be angry at us or not trusting is it feels very damaging to us. And I think there's another fear, and that is that even though we're supposed to now be not a shame and blame culture, we still are. And even if in our own medical institutions we got past the shame and blame, which we're working very hard towards doing, society is shame and blame. What's the malpractice system but a very specific shame and blame? It doesn't really look at systems when things go wrong. It looks to who can we blame and who can we punish. And so there's a sense of betrayal, I think, by sometimes by our colleagues, but really more important by society itself, that is this what's supposed to be happening afterwards? And I think that all of these emotions can lead to a real sense of being isolated. And as we all know, being isolated, humans are really social animals, and being isolated is unbelievably stressful and something we should really try to avoid. Mm-hmm. So I think peer support really speaks to dealing with this sense of isolation and trying to prevent it. I mean, anytime we talk about peer support, I think all of us hold in our minds the people who are most important to support after something goes wrong in any way, shape, or form would be the patient and the family. Clearly, they deserve the support. What we do recognize now is that for us as a healthcare team and individuals, for us to provide that support, we ourselves have to feel whole. And that, I think, is why peer support is so important, because at the end of the day, if we can be supported and we can feel whole, we can do a better job at being transparent and compassionate with our patients after something goes wrong. And also, we want to recognize that the team itself can be traumatized, the whole healthcare team, and sometimes an entire institution is traumatized after an emotionally stressful event, depending on what that is. We also know that most of us, we've all made errors because we're human. And most of us do recover, as Bryan has and I have, from the mistakes I've made. But we also know that sometimes recovery is thwarted. And that thwarted recovery can really have a negative impact both on the clinicians themselves and then subsequently on their patients. We actually were involved in a study where we looked at a cross-cultural study between the UK and the US site being the Brigham and Women's Hospital, where we did a survey study with interviews asking about the emotional impact of errors on clinicians, both nurses and physicians. And not surprisingly, many people were impacted for a long period of time. In fact, we found that 30% had a significantly negative impact on their relationships with colleagues and then their own performance at work. And that's a statistic to really key on, because that can translate into really downstream bad effects on both patients, families, and then clinicians themselves. It's also well known that there's a higher risk if you've made an error or if you perceive you've made an error of becoming burnt out or depressed. And so it's a vicious cycle where if you make an error, you can become burnt out. We also know that if you become burnt out, you have a higher chance of making a medical error. So we wanted to interrupt that cycle, mm-hmm. as Bryan was saying. And finally, we know from the literature that we're not very good, physicians in particular are not good around having compassionate and transparent disclosure conversations with patients after errors. Well, if you think about that, no wonder, because if you ask me to go in and talk to a patient and tell exactly what's happened and be compassionate, and I'm feeling ashamed and guilty and sad and fearful and isolated, the chance of my doing a good job at disclosure, a compassionate and transparent disclosure, is not high. Mm-hmm. And so we also feel that peer support could affect, in a positive way, the way we can show up for our patients, particularly after adverse events.
Mm-hmm. Thank you, Joe, and thank you, Bryan. Joe, you've had the opportunity to start many peer support programs in different organizations. Do they all look the same? Is it a one-size-fits-all, or how can you tailor it to the different organizational needs?
Absolutely has to be tailored, I think. I think what's common, and as Bryan pointed out, it's common that we're human, and so the error rates are the same across institutions. The kinds of emotions people feel are very thematic, as I said, although individual in the moment. so at least the underpinnings of peer support, the reasons to do it, and the kinds of outreaches are very similar from institution to institution. I think what's can be very different is depending on the culture of the institution and how people interact with each other. That will change how a peer support program is rolled out. And so for example, working with you all, it was very important for me to come and not talk about this is the way we do it and this is the way you should do it, but to think about, well, at Stanford, how do you relate to each other, and what are the ways of communication? What resources are available currently for physicians and other clinicians involved, for example, in errors, and how well are they utilized? Mm-hmm. So for example, a lot of places do have a vigorous employee assistance program, but we found it at our institution that it was underutilized. Mm-hmm. They're a great resource, but not really helpful to physicians if they're not connected with EAP. Mm-hmm. Same thing with psychiatry. Really great. We have wonderful psychiatrists, but physicians weren't going to psychiatrists after adverse events. And so we have to understand at an institution, what do you have now for resources? Who's utilizing them? And who are people likely to connect with? And then tailor the program for that institution.
Oh, thank you. Bryan, you had a unique experience in that you were able to start the program at both the adult hospital and the children's hospital, and sometimes we hear that things are different at a children's hospital. Can you talk to the organizational culture of how we were able to use one overarching peer support program that covers both organizations?
Yeah, we were fortunate in that we had, when we formed our wellness committee, we did this as a Stanford Medicine Committee rather than an adult or a children's hospital committee. And so we already had several people from the children's hospital as well as a large number from the adult hospital on our committee when we were considering the program. And they knew the ins and outs of their own part of the organization in a way that helped us to construct the program so that it would fit both, and that we engaged both sides of both hospitals at the same time.
Great, thank you. Thank you both. Now let's explore how to operationalize a peer support program. Joe, you spoke a little bit already about the existing programs such as EAP and psychiatry. Can you tell our audience a little bit more about why it is important to have a peer-to-peer and what that really looks like and how that helps build resiliency?
I certainly can, Dana. One thing that we noticed was, well, we decided to go ahead and start peer support. So we did model it again after the first responders, and we had group peer support offered. And what we found was that it really worked well for certain members of the healthcare team. So, for example, after an adverse event, we would say, we're going to have a group peer support offered in the anesthesia lounge at noon. And a lot of times, so many different people from the healthcare team would show up. There'd be nurses, patient care assistants, managers, all sorts of different people. But we noticed that rarely were physicians showing up. Maybe a resident would be there, not likely, but sometimes. But the physician, attending physician, the faculty physician, would rarely be there. Or if he or she was there, it would usually be in the role of team leader. And, you did great, and it's okay, and thanks for all your hard work. But we never saw a faculty physician say, I feel terrible. I feel incompetent. I'm really feeling afraid. And what we understood was that's probably a cultural issue. So we decided to look into that further, and we did a survey of physicians in particular, because they were they utilized the group peer support least. Mm-hmm. And we asked a lot around emotional stressors, all different kinds, and what they'd experienced over the past year. And there was a high percent of physicians who had experienced some form of significantly emotionally stressful event within the last year. And we specifically asked about adverse events. Who, if you were involved in an adverse event, who would you want to get support from? And we gave lots of choices, EAP, all sorts of other resources, again, which we have so many of. And almost 90% of physicians wanted to speak to a peer. In this case, a physician colleague. Mm-hmm. So what we did was we modified our program. We still have group peer support, which can be very helpful, especially if a whole team is affected. But we also have it for one-on-one for physicians. Mm-hmm. then we also noticed, and also clinicians who are maybe at the sharp end of an error. The nurse who's actually been the person who put the wrong medicine in the IV, a group peer support is not really going to be helpful to that person, most likely. So we modified the program. We added this one-on-one peer-to-peer support. Unfortunately, nobody called us. So we trained about almost 60 peer supporters, and nobody accessed us. And then we realized, if we look back in our study results, it's pretty obvious that some of the barriers to reaching out to a peer or for any other resource after an adverse event, the barriers like fear of reputation and fear of lack of confidentiality, that we needed to do something to help people hurdle those barriers. And so what we further modified the program for was, we don't wait for people to call, we reach out to them proactively. And that's been a huge improvement in terms of people actually getting peer support now.
Wonderful, wonderful. Bryan, thank you for that, Joe. Bryan, you started the program after Joe came to visit. So Joe comes out to visit us. And then where did we go after that?
So Joe came in October of 2013. And what we did is we decided to seek out the key physician leaders in our organization from whom we thought we needed support for this program. So we selected, we sought input from folks that were in departments where these sorts of incidents are more likely to happen, in the OR, anesthesia, surgery, in the ED, in the intensive care unit. Not that they don't happen everywhere, but those are sort of the hot spots. And we asked folks if they thought that this was going to be helpful. They asked, we sort of talked to them about the program that they had at Brigham and Women's. It helped that it was a good program that was already established at a really high reputation organization. And what we found is people really almost immediately recognized that this might be a good idea at Stanford as well. So we were fortunate that way. We weren't meeting resistance. And what we were doing is just gathering allies to make this work. And so what we did is we decided to go ahead and start training with Joe's help after her. I should say also we had the site visit from Joe, and she visited our wellness committee. We invited people to come and hear the discussion there. She was able to visit some of the leaders of our medical center as well, our dean and others. And there was support all around, and we went ahead and decided to start training peer supporters. And we followed a lot of the practices that Joe had worked out already in Boston. We trained mostly folks that were already on our wellness committee, but also some others we asked all the chiefs of service in our organization to recommend people who they thought might be excellent peer supporters. Because when we got to do the peer supporting, we often want to use supporters from the same or a sort of a related specialty to do the peer support. So all of our peer supporters attended initial and then ongoing peer support training. We made it very clear to everyone along the way that this is not mental health, that this is, and we do have a mental health connection called Welle Connect that is available for folks that really do need that. Usually that's not the case after these incidents. Usually the peer support is what folks need. And we want to be very clear that that it's not a psychiatric disorder to have distress and to need help after an event like this. We developed a process, again, modeled after what Joe had done. When an event happens and we learn of it, the peer support director is notified by risk or by the quality department or by anyone else in the organization. And as we've progressed through the early stages of this, we've gotten more and more awareness so that people start to tell us about these incidents earlier on. The director contacts our peer support team. The peer supporter contacts the person involved. We didn't have to go through the learning process of waiting for them to come to us. We contact them by phone. We send them an email containing the options. It suggests that you call. It doesn't demand it. Materials about the program are sent. We have a very careful scripting of the call and the email so that it's well received by the recipients, doesn't feel in any way threatening or violating of confidentiality, that sort of thing. And the process slide here includes for our house officers. And we'll get into that, but basically one of the supporters is available to meet with the person who was involved in the incident. I think about 50% of folks that were contacted are taking advantage of that. And then our risk department keeps track of the metrics in terms of how many people do that. And the feedback that we've gotten in terms of anecdotal report are things like you see on this slide. We really enjoyed the training from our trainers. It felt like the organization is showing appreciation. Folks that are contacted by this peer supporters have been almost unanimously very appreciative, even when they said they didn't need peer support after an incident. Early on, I was doing some of this myself, and I can tell you that there was just a palpable sense of appreciation, that somebody cared, that somebody was asking how they were doing, especially when I contacted house officers. And I have to say that some of the house officers relayed stories of feeling very isolated. Their attending didn't ask, they didn't know what to say, they didn't know how to ask. They had to go right back to caring for patients after they had an error. And they really were suffering, and I feel like just from my own brief experience, because I have not been an ongoing peer supporter, that it was really quite impactful. And then as the program has gone on, we find clinicians self-referring to the program as well, that they know we exist, and they reach out to us once in a while. The house staff program came after the original one with the medical staff. And originally we thought, well, the house officers, what we'll do is we'll find young faculty who can mentor or can counsel them, because they're only here for 3-5 years, and it's going to be hard to train them, and they're so busy and they won't be able to do this. But as we met with the house officers in order to plan the program out and get buy-in from them and from Larry Katz-Nelson, who's our head of graduate medical education, we did some focus groups, and they were not interested in the faculty doing their peer support. They wanted to do it themselves. We were really heartened by that. They were absolutely interested in putting in the time to do the training. The chief residents felt like this should be their responsibility, and they really stepped up, and that was something that really made us all very excited. And so they're doing this themselves. They have a faculty peer supporter on their team that helps them, that counsels them and helps with the training, and that's been working out really well. We're not that far into it. It hasn't been that long. The medical staff program only started in June of 2015. We have 41 interventions since then, including, and for fellows, we've been using young faculty members. We don't have that one figured out totally yet. We began surveying the folks in terms of how they're feeling about the interventions. We have 15 trained peer supporters between the children's and the adult hospital. And that's for medical staff. In the house staff side, we began later. We began about 6 months later. We have 8 house staff members who are trained to do support. We've had 13 interventions. Training is going to now be offered to all of the incoming chief residents, and then selected residents as well are invited to take leadership role in the program, so we have some continuity between the years. And the resident peer supporters, as I said, they have faculty advisors as well. So it's been extremely well received. The early indications in this program are that people appreciate it, they benefit from it. There were a lot of early concerns as we did our focus groups about things like confidentiality, about legal risk in terms of talking about things, and maybe Dana could speak about that at some point, but there is no real problem with that. And those concerns really have just melted away as the programs become more ingrained in the organization.
I was going to just interrupt if that's
Absolutely.
okay. Some of the issues that you raised, Bryan, I wanted to comment on. A lot of times people ask, why do you actually need to train anybody to do this? I mean, it seems, just tell everybody to be nice to each other and ask how they're doing. And there is some truth in that, informal peer support is really important too. So we're not saying, only fully trained peer supporters should talk to their colleagues. But I will say that asking someone to do peer support, a physician or a nurse, is asking us to do something that we are not used to doing, and that is to be able to sit with someone else's pain. We are usually, if someone comes to us for something, we want to fix them. That's my job as a surgeon. You have a problem, I don't, say to you, well, which approach do you think, I should use to take care of that growth? I mean, of course, we're doing things in partnership, but mainly we are there. People come to us to fix their problems, and this is not a fix-it situation. On the other hand, being listened to, very deeply and directly by a colleague who understands what it feels like to have this burden of having harmed somebody, or even just seeing something emotionally stressful in medicine, is so helpful and so healing in and of itself. So what we have to do in the training is we have to teach people, physicians and other clinicians, to listen without the goal of fixing. And that actually takes some work to do, and we do a lot of role play, as you know, Bryan, in the training. And then I think the other thing is that unlike psychotherapy, where I think psychotherapists are extremely well trained to listen, this actually, in addition, requires some sharing. So if I'm peer supporting you, and all I do is nod and say, "Wow, that sounds incredibly horrible," and you're thinking, "Well, gosh, she maybe has never felt this." It's part of our training of the peer supporters to share to some degree. I don't know how you're feeling exactly, but after I made an error that I think of all the time when we talk about peer support, I felt pretty awful. I kept going over and over the event in my mind. Is that something that's happening with you? So being able to give of yourself, but not too much, and also to listen, but not just listen. And the other thing is that we tend to, and because we're trained to, be very judgmental and rigorous about listening to things that happened in healthcare and wanting to make them better. And so there's a part of us that wants to critique the care. And that absolutely is, we train the peer supporters, it's not a critique situation. That should absolutely happen, but that would be in a different forum, in morbidity and mortality conference, a quality conference, what have you, but not in peer support. We're not there to critique. And it's why some of our peer supporters are, and I've done a lot of individual peer support, I may be peer supporting someone completely outside of my specialty. In fact, most of the times I am. I don't have a right to, or the experience or expertise to critique the actual event. So I think that's an important part of training as well. So the other caution is that not everybody does want to or need to talk about an event. And to push somebody to do it is also wrong. And so that's part of the training, again, as Bryan and you know quite well, it's an offer. We make it easy, so we don't say we're here and call us if you need us. But so it's an outreach, but it's an invitation, and there is absolutely nothing wrong with 50% or whatever the percentage of people are saying, "Thanks anyway, I'm good, it's okay." So I think that's important. And the very last thing that I wanted to say, just in response to what you were saying, Bryan, is, which you alluded to, is we're not really asking or wanting clinicians not to feel, not to have these emotions. It is absolutely part, that's what being human is. If you care about somebody, a patient, which we all do care about our patients, of course it will hurt if bad things happen to the patients, especially if you had a hand in that. It's more a matter of managing the emotions. So first of all, you can heal, and second of all, so you can be there for the patient and family.
Thank you, Jo. And that's really, you are a national leader in peer support programs, and you've shared previously with us and how your program has evolved over time. Can you share with our audience some of the challenges that you faced, some of the considerations for future growth and sustainability of peer support programs?
Sure, I'd be happy to. We always want to share our successes and our failures too, so I'm happy to do that, because we're all learning. Nobody really has any proof of what's the best way to go about building resilience and facilitating recovery after emotionally stressful events. But we do know from trauma literature that there's a reason to believe that this would be helpful, and then we have the studies supporting that it's what clinicians want. So I think one thing that's been helpful, I'll say on a positive side for us, is just really the rock-steady institutional support that our leaders really recognized. This is important. And to really run a program, it's not wildly expensive, but you can't just hope everything is done with volunteer work and no structure, no organization, no administrative support. So I think we have learned that, in fact, because it did start out as all volunteer, and eventually we said we need some support, and they've been great about doing that. So, and I know that you have that institutional support as well. The other question was, well, who should be a peer supporter? And we started out with volunteers. I'd like to do that. And the problem with that is a couple things. One is that you the desire to do something is great. Of course, it's necessary, but it's really not sufficient in understanding whether you'd actually be good at doing it or not. So there are two things that we found people wanted from a peer supporter. One is they needed the person to have some credibility in terms of their clinical expertise, not even in their specialty, as I said, but just knowing that is a clinician in good standing. Because, if you're going to support me and I know that maybe you aren't the person I'd respect clinically. And this sounds awfully harsh, and I don't mean it to be, but there have to be clinicians who really get it and who are, active clinically in some way or have been and have a reputation for being good clinicians. And the other thing is it requires a degree of relational skill that's pretty high for the reasons I said before. And so what we did was we went from volunteers to actually going to the departments with the support of their chair or chief and saying, we're going to send out this email describing the peer support program, and then ask nominations from the faculty and residents. Who would you want to support you in an emotionally stressful event such as an error? And so they're all peer nominated peer supporters, and that really made a difference. So that's been very helpful. I think where we are not doing as well as we want is, how do we know somebody needs support? Well, first of all, we're not waiting till people are suffering. So our premise is we're going to support anybody involved in a potentially emotionally stressful event. And so if we're not hearing about those events, then how do we know to go and reach out? And I think we know in our institution, and it's not like we've studied this, but we just know it from empiric data and other studies, that there are things that happen that don't get reported. So how do we know about that, and also encourage reporting more, which is really important in being a learning organization. So we're trying to work on that. And the other question is, do you support how do you assign the peer supporter? And does it need to be someone in the specialty of the peer? And our conclusion has been, and just from really our practicing this for several years, is it doesn't necessarily have to be a match that way. We do think that if the injury or the trauma, if you will, or the error or the event is an interventional one, then it's probably important to pair the peer with an interventionalist. It doesn't have to be in his or her specialty, because making an interventional injury it feels very, just in some way different. And so that's been helpful. And the other thing is we don't assign a junior peer supporter to a senior peer just because of that sense of, you want someone with your level of experience anyway to be peer supporting you. The other question is follow-up. What we've trained, and I'd be curious to hear what you do at Stanford now, is we've trained the peer supporters to have this be an intervention that has one follow-up call at least. Is it okay if I get back to you in a week or so and check on you, asking permission? But we don't do ongoing peer support. What we do is, if somebody feels that he or she really is not, recovering in the way that seems okay, that this event is interfering with their work or their home life, or in any way they feel they need more support, our job as peer supporters is to connect them with resources. And so we see ourselves as connectors, because it seems to be more acceptable if you recommend to me, Bryan, that, Joe, hey, it sounds like you're still suffering. I have the name of a psychiatrist. We do have those on our team, if you will, ready to be available, or someone in EAP, rather than I have to identify myself as having, a problem that needs psychiatric help. So just getting over that barrier. But we're not really sure, is that right? Is just one follow-up intervention enough? So I do wonder about that. We're holding that as a question. And the other is, peer support is hard. In some way, it's really rewarding. Bryan mentioned that. It just feels so good, because people are quite appreciative. They, thank you so much for calling. This was helpful. But still, we're holding other people's sadness and stress. And so we believe firmly that we need to support the supporters. So we do have quarterly meetings. We also have a way they can call me as head of the program if they have issues, questions. And I have had peer supporters feel in a quandary about a certain peer support and how it went, or maybe somebody needed further help and they wanted to help me guide them. And then how do you assess the program? You know, we've been a little reluctant to interview those peers who we've supported because of the sense of we don't want to, you know, re-traumatize them or invade their privacy. But I think we're far enough out years-wise that we're going to, well, I know we are, that we're going to do a study to really look in more in-depth qualitatively of what was helpful, what wasn't, were we there, weren't we there, and in what way. And I think the other point is that we've really now integrated the peer support program into our disclosure coaching program. So we found that there are a lot of times when the conversation, the planned conversation with a patient and family, which may, once we discover something has gone wrong, may not be for weeks after we've interacted with the patient. We found that that is a moment where, first of all, disclosure coaching is helpful, where we can help the clinician, you know, in conjunction with risk management, plan how to speak to the family, but helping the clinician identify what emotions he or she is feeling so that those emotions don't go into the room virtually with the patient.
Do you feel that the person, the physician champion, if you will, that should start a peer support program, do they need to be on that level of chief of staff, chairman of the department, or can any physician who has this as a passion take this on for their organization?
I don't think that it needs to be someone in an official capacity like that. I think it helps. They're there where they can get some resources, they can get some attention from folks in the organization. What I do think is it needs to be someone, like Joe said, for a peer supporter. It needs to be someone who is a respected clinician in the organization. It can't be someone who someone will say, well, yeah, sure, Joe would say that. She's not very good at this and she needs a lot of support. It has to be someone who you'd say, wow, if Joe says that, then it must be meaningful. It must mean something to her, and I respect her as a clinician. So usually a senior, well-respected doctor, it seems to me, is the best source of sort of the energy to get this moving.
Thank you. Thank you both very much. We have a couple questions from our audience, and Joe, I'm going to direct the first one to you because the program at Stanford has been less than a year. Can you speak to a question about how to actually bring peer support to the entire organization? It doesn't have to just be an error. Is there a way to make it more part of the culture of the things that you do? You shared with us the tragic shooting of one of your colleagues and how you were able to use peer support. Perhaps that would help answer this question.
Yes, unfortunately, our colleague Mike Davidson was shot in the hospital and killed, and had there was about 8 hours worth of unbelievably intensive work, care, intraoperatively to try to save his life, and we had the peer support available and knew that if there's an event so traumatic that is likely to affect our colleagues, that this is exactly the time we'd want to offer that. And so what we did was we offered a series of group peer support. For all the different groups we could think of who might have in any way been involved or affected. And that was, of course, a ripple effect, not just those of us who knew him, but people who worked with him a lot, or people who, who were in the clinic or what have you. There were so many healthcare team members who were affected. So we used both the group peer support, as I said, and then we also understood that there were individual clinicians who were really, really going to be impacted. Not necessarily, but we thought there were so at risk for, and at risk for feeling awful after this, and also deserving of the support. So we mobilized all of our trained peer supporters and assigned one-on-one outreach to each of the clinicians. One thing that we did do in that instance that has changed a little bit, my thought around the peer support outreach is, in this setting where the trauma was so high, the emotional fallout, is usually when I would reach out to a peer for support, I would say, would it explain the program? Would it be helpful to sit to talk? I would ask them that question, and if they said yes, we would talk, and if not, that's fine. But in this instance, I actually would reach out and say, do you have a couple minutes? I just want to meet with you. And I found that just sitting with people who I think likely might have said, no thanks, I'm fine, just because that a lot, of my colleagues are surgeons and anesthesiologists, sort of more like, I'm tough and it's okay, I can deal with this even though it's horrible. Just sitting with them and letting them just talk about what they went through, I think was helpful. At least that was the feedback that I got directly from them. So we learned from that sometimes really even just being more present and providing that I'm sitting here with you as a colleague can be really, really powerful.
Thank you. Thank you for sharing that story. Bryan, you talked a little bit about it, the confidentiality issues, not so much from a risk standpoint, but just in California, we're lucky we have CEC 1157, which protects certain things from discoverability. How were you able to help sort of smooth the concerns about confidentiality through the organization to allow people to feel like they could use the peer support program?
It was a remarkably persistent issue because, as Dana says, in California we have protection because this is a medical staff initiated program. It's a quality improvement program. It falls under the protection of our state law that protects from discovery those sorts of activities. And so we would say that, but people were not really believing it. And so it basically just took conversations and repeated reassurance that this wasn't being written down, for one thing, that there was not a record kept of any of the content of what we were talking about, and then that even if someone was subpoenaed to talk about what the conversation, what was the content of the conversation, they would not have to respond to that subpoena. It would be protected. And so really it's a non-issue. It's just that it just, I think, highlights the sensitivity of folks when they're in these kinds of situations that they're vulnerable. They feel a sense of vulnerability and it's hard to reassure them that they're safe.
Right.
Well, and Dana, as you know, in Massachusetts, these are not protected conversations. And we really wrestled with our risk managers and our medical malpractice insurers, CRICO, and the defense malpractice attorneys. And we really talked a lot about, well, how can we do this if it makes clinicians vulnerable to having the conversation discovered with a lawsuit. And we actually decided we're going to do this because it's the right thing to do. Of course it should be protected, but it isn't. And rather than changing the law, which I'm not in a position to do, we are going to do it. And we're going to put certain safeguards in, as Bryan mentioned. We don't take any notes for any of the conversations. We actually just, this is off the record, if you will. And we don't. I mean, we listen to what happened with the event, but we're really not there in a judging kind of technical root cause analysis kind of mindset. So we're still doing it, and it seems it's interesting. It seems okay. People accept it, that it's part of the program and it's blessed by the institution. So I guess it's okay.
Well, thank you both very, very much. I am sure our audience has appreciated your expertise and insight, as well as your candor with your personal stories. We all hope this webcast has helped to highlight the importance and need for peer support. You have given us some resources to explore and how to implement and operationalize a peer support program. And we hope that our audience can use some takeaways to start a peer support program in their own organization. If we didn't get to your question today, we will follow up with you online. If you have colleagues who you think would benefit from watching today's program, we'll have the full webcast and selected clips available for viewing on demand in about a week's time. A final thanks to Joe and Bryan for being with us, and to our partners for supporting this event, from Aon Risk Solutions, Lockton UK, and the MedPro Group. I'm Dana Welle with the Risk Authority. We want to thank you for joining us today.